Yeah, so I'm here from I'm zooming in from Colorado where I'm visiting family, but I live in London in Stratford. This is something that hits very close to home for me. I'm wearing a few hats in terms of lived experience that I'd like to speak from. One is I've just named it both an American by birth and as someone who's made my home in the UK. So I've lived in states where this has been legalized, and as a person who has recovered from an eating disorder and who now supports others on their path to recovery, I have seen the impact that such laws have had on people that one may not think would qualify as terminally ill, but who have indeed qualified as terminally ill for complications related to an eating disorder, for malnutrition, terminal malnutrition, as they've called it. So I speak from as a person running a nonprofit that supports people with eating disorders. I speak as a researcher. I did a study that was published in August, and we found 60 documented cases where people with eating disorders were euthanized or assisted in suicide for reasons solely related to an eating disorder. And I have to emphasize that most of the data is not visible to researchers. So 60 cases in the tiny fraction of publicly available data we were able to review. In most cases, we couldn't even confirm or deny whether cases had occurred. Most relevant to the bill being considered in the UK, we confirmed people with eating disorders had been assisted in suicide by physicians in 3 US states, in Colorado, where I'm speaking from now, in Oregon, which is often hailed as the epitome of safeguarding, whatever that means, and in California. I cannot confirm how many people have died because the oversight agencies will not release that information. They will only confirm that anorexia has been listed by name as a qualifying terminal condition, and that women, generally young women, have been prescribed lethal medications on that basis. So I can say that cases have occurred here, but I can't say how many, which is a real issue for public safety. Um, our research also identified that in at least 2 US states, and I've only checked in 2 US states so far, that malnutrition has been listed as a qualifying terminal condition. And to be clear, this is not malnutrition related to a primary terminal illness of cancer. This was the primary terminal illness listed, and that's particularly remarkable because malnutrition is an entirely reversible condition. It can be reversed with feeding. Food is the medicine for malnutrition. So that is remarkable. I can't confirm whether those were anorexia cases or not, again, because the cases aren't available. So I speak as a researcher, as someone leading a charity, but I also speak from personal experience with an eating disorder. And I know often we don't think of people with eating disorders, at least in common practice, as disabled people, but I would really beg to differ. It's absolutely a disabling illness in today's society in terms of how we treat people dealing with mental distress, physically, mentally, emotionally, socially, culturally. And 17 years ago, 19 years ago, actually, 19 years ago, this past July, I was hospitalized with multiple failing organs. I was unable to walk. My skin was yellow from liver failure. I no longer had control over my bladder. I was very, very ill. I was placed on a cardiac ward. And I was told by the doctor as soon as I arrived that she didn't believe she could keep me alive for much longer. And the best thing they could do was really make me comfortable. That was not because she was a malevolent doctor. She really believed that about my condition. I'd been starving for a very long time, and my body was shutting down. And I have to say, from the inside of that experience, I didn't want to live anymore. I felt I felt like my body was broken. I'd been taken out of my family. I was locked in a hospital. I'd been battling a horrible, horrible mental illness, if you want to call it that, but an experience of suffering for many years that was rooted in trauma. And I didn't see a future for myself. And I certainly didn't see a future for myself, given how much damage I'd done to my body, that I felt, given what I was being told was, quote, irremediable, was terminal. And I begged doctors to let me die. If assisted suicide, assisted dying, if you want to call it that, euthanasia, if lethal medications had been available to me at that time, I 100% would have taken it. I asked, I asked. And I have to really emphasize this because I feel like we are often written off as, oh, you're not the ones this would affect, this isn't about you. This is about these terminally ill people over here. Well, actually, I beg to differ. It would affect me and it would affect my community. I think at the heart of what we're saying is don't give us lethal medications in our most despairing moments. That is a very base level request. In a healthcare system, we're asking that physicians do not make lethal medications available to us in our most despairing moments. In those moments, we need treatment, we need care, we need support. We need financial support. We need everyone here has already spoken to this. I am very, very grateful that thanks to a quirk of the healthcare system where I lived at that time, I was placed into the custodianship of the hospital. So I was legally mandated to receive treatment for 16 months. And the first 6 months of that, I was suicidal. I was kicking and screaming. I didn't want to eat. I tried to tell my doctors multiple times that, this was my path. I was meant to die and just to let me be. I'm grateful that they did not listen to me. I'm now 35. I have a wonderful life. I have dedicated my career to helping others out of this kind of suffering that I was experiencing. And I've dedicated my career to doing the research to ensure that really good treatments are available to people in those moments and really good care and support are available. But in this current system, the people I work with are often on waiting lists for 9 months, 10 months, 11 months. Over that time, their illness and their condition becomes worse and worse. So by the time they are hospitalized, they are hopeless, they're suicidal, they don't feel like there's anything left to work for. And sadly, often when they are hospitalized, they are ostracized and stigmatized, sometimes by the very clinicians responsible for treating them. There are amazing physicians out there. I'm lucky I had amazing physicians. I work with amazing physicians who are wonderful and compassionate, but we would be lying if we were to say that there is no stigma against people with any kind of physical, terminal, whatever you want to call it in our healthcare system. And they're often mislabeled as terminal. I want to speak to what I think has been a real I don't know what else to call it, but some misinformation floating around out there. People who have been assisted in suicide by physicians in the US did not have co-occurring, with eating disorders, did not have co-occurring terminal illness. They had a treatable mental health condition, and they were labeled as untreatable by the physicians who were responsible for treating them. None of them, zero, had irreversible organ failure. Some of them were not even underweight. Many of them had never even received a full course of treatment. So I speak from the evidence that I'm looking at as a researcher, as a fellow human being. We have to talk about the evidence from other jurisdictions. We can't just write that off and say, oh, this won't apply to people with eating disorders. I appreciated that Ellen at the top of this spoke about the risks of expansion of the bill, which are real. But I would say in the bill that we are looking at right now, even if no expansion happens, the way terminal illness is defined, a person who is chronically malnourished, yes, related to a mental illness, but chronically malnourished would absolutely qualify because it contains this word called only. A person only with a mental illness or only with a disability won't qualify. But of course, people with mental illness have co-occurring conditions. So yes, in the way this is written, young women with anorexia could qualify. The other concerning thing is that in Oregon, we've seen terminal illness, because of the way it's defined, interpreted as any condition that will result in death within 6 months with or without treatment. So a person who chooses to forgo treatment or more commonly can't access treatment in a timely way could be dubbed or deemed terminal, not because they have an illness that would result in death with treatment, but because they can't get care, and because again they're in those last despairing moments. So in Oregon, we've seen people with diabetes given lethal medications because they don't have access or choose to forego insulin. That is a terminal illness if it's untreated. So there's nothing in this current bill that would prevent that from happening. And that's one of my biggest concerns, is that a chronic condition can be transformed into a terminal one with the systemic problems in our healthcare system. It also concerns me that mental illness or mental distress is just written off as, oh, that's not relevant here, when of course mental illness and mental distress don't exist independent from chronic health conditions, from injuries, from impairments, any of those things. So I think it's really important to take that into consideration. We published, along with, this is the last thing I'll say, with 16 physicians from around the world, from Canada, from the United States, from the UK, two of whom hold senior leadership positions in the Royal College of Psychiatrists. We just this week published an open letter in the BMJ, and our main thrust of this is that this bill fails the public safety test. And so if you are considering abstaining from this vote, or you are considering voting yes, like the others with lived experience, I urge you to reconsider. I urge you to look at the international evidence at how this has played out in other jurisdictions. It's relevant. And I urge you to ensure that this is given the time it needs to really take into consideration all the risks to people who are already marginalized in our society today.